everybody, and welcome to this edition of MacroPro and Friends. Here at MacroPro University, we are proud to be bringing you our summer series. We have 10 webinars that we will be providing to you during June. And today I have Cindy Mariani and Dr. Mir, who is going to be our speaker today. Hello, how are the both of you?
Good, thank you. How's everyone? Happy
Wonderful,
Friday.
Diane.
So, Doctor, you just finished with surgery, right?
That is correct.
So tell us, what surgeries were you performing?
I had two patients this morning, cervical spine surgery, doing a decompression, taking the pressure off, and I did a disc replacement on both of them.
Wow. Well, we are so delighted that you're here and that you're invigorated by doing those and you're able to be part of our webinar series today. Cindy, how are you, Cindy?
Great. Thank you so much. Thank you for hosting, Diane. I appreciate you.
Oh, well, you're quite welcome. Now, Cindy, you are with SMS, right? And you actually brought
SMS National, a few more weeks.
a few more weeks.
Absolutely.
Well, I know you've been in the industry for a long time, and let me just say that we are all going to miss you very, very much. Now, before I do our housekeeping, Doctor, I understand that you received a couple awards recently. Could you tell us what awards you got? Because I think it's interesting for our audience. They should know, I know you probably don't want to pat yourself on the back, but they should know that you're a badass doctor, and we really bring them the best to our webinars.
No, thank you. Yeah, I actually just today I got an award from the disc replacement company ProDisc, which they're the largest and they have the longest track record. I've been using them since in fellowship, 20 years now. Yeah, they just gave me an award for like doing, passing the milestone of doing over 100 something cases. I don't have the picture of it, but yeah, that's one. Um, and there's another one I received. It was from City of Huntington Beach. It was a sign of a placard of appreciation for taking care of their injured workers. They have what's called a fast track, and it was an event. The mayor was there, and they talked about how the fast track program with the selected doctors have really saved them a couple $1 million by getting him in, treating him very quickly without authorization. And they also got rid of some of the third party discounts that some of the carriers have. So it was a huge plus. The injured workers are back to work, and we're very happy with that.
Well, we are delighted you received them. They're well earned, I am sure, and we are so happy that you are going to be able to speak to our audience today about sports medicine. So, real quick, I'm just do a little bit of housekeeping, and then Cindy, I'm going to turn it over to you. So, today's webinar is worth 1 CEU here in California. I want to make sure that you stay logged on so that you are on for at least 50 minutes to receive your certificate. Your certificate should arrive to you within a day. And by the way, Doctor, people were applauding when we were announcing your awards. So the audience were giving us little emojis of hand clapping. All right, so then we have handouts. You can go ahead and download those as well. If you have any questions, put them in the question box, and Cindy's going to be monitoring that and asking Doctor questions. If we can't get to it exactly when you are writing the questions, no problem. We'll try to catch them at the end of the program, and then you can watch this again on the MacroPro YouTube channel where all of our programs are listed. So, Cindy, I'm going to turn it over to you, and if anybody needs help with their certificate, I can help you for 30 days, and that's important to know. So after 30 days, I'm not going to be able to do that. So please let me know if there's anything that you need me to help you with.
Well, thank you, Diane. I appreciate you and MacroPro again for hosting the webinar. I've been asked to co-host because I've known Dr. Mir, over 15 years or so now. And really, he is one of the premier spine specialists in the country. He's a board certified spine surgeon, a back and neck specialist with fellowship training in combined neurosurgery and orthopedic surgery. He specializes in cervical, thoracic, and lumbar issues. I can really go on and on about him, but let me cut it short. Let him tell you a little bit more about himself and get on with the presentation. Thank you all.
Well, thanks for everyone. Well, thanks for spending your Friday afternoon. I appreciate it. Yeah, I mean, when you think of spine surgery and spine surgeons, probably that's not your favorite specialist. You think of patients getting, you know, disability, not getting back to work, or other issues and complications. Hopefully, I can provide some information about spine injuries and treatment of spine injuries. So, we got my main office in Tustin, and we have satellite office in Long Beach and Riverside. So just a little bit by my background. I did undergraduate in UCSD, and then went on to medical school in New York. I did 5 years of residency in Chicago, and I did a combined neurosurgical orthopedic spine fellowship at Cedars back in 2004. And I've been, in private practice ever since. I have local privileges. I mainly do surgeries at Orange County, at Providence, Foothill, and surgical centers. So, you guys, just want to play this video of a patient that just was afraid of going surgery for a long time. Fear of getting paralyzed, fear of having issues, and she finally did the surgery and did amazing. I'm going to see how this audio comes out. So please tell me how this comes out.
Hi. So
Can you guys hear this?
Please tell us what kind of surgery you had and how you're doing now.
Yes, we can.
Linda Vasquez. I hesitated to get neck surgery because of the stiffness, the people having pain with the hardware and everything. Because I do have friends that had the screws. Now with the new disc hardware, I'm pain free.
When was your surgery?
My surgery was January 27th of this year.
How was your recovery?
It was amazing. No pain. I woke up with literally no pain. I've been dealing with a lot of pain since 2017 when I had an accident at work. So it's taking me this long to get myself to this stage. And I am very happy and very pleased with the surgery.
And what do you do for a living?
I work outside construction for Edison. I'm the only female out in the field. I have my Class A. I also drive. I'm below alignment. So my head is always high, looking at the pole with the guys and looking at the ground for the guys. So, and I'm an equipment operator also.
Great. Why don't you move your neck up and down so we can see how you move up again, side to side, the other way? Okay, great. And you had the disc replacement surgery, right?
Yes.
Okay, perfect. Well, thank you.
So, yeah, and then this is her
Full-time duty.
when she returned back to work.
No restrictions, doing good, no pain, just a little tightness, but that's it. But overall, it's a successful surgery. Very happy, no pain.
Very good. I'm glad you're back to work and everything's good.
So these are like examples of people suffering from
Okay.
really
nice.
these type of issues, and when they have the surgery, they're actually pretty surprised of how well they do. This implant I use, this is by ProDisc. You can see there are metals on both sides. In the middle is a polyethylene, so it allows motion. It's a very natural thing. So the recovery is very quick, and also you don't have any long-term issues. So you don't have any adjacent segment breakdowns and having redo surgeries and things like that. So overall, it's a very successful surgery. This is what it looks like when you bend. You can see there's motion, very natural. You flex forward and backwards. You can see here how the disc is moving forward and backwards. This is just another example of a patient with a cord compression that underwent the surgery. On the MRI, you can see there's compression, and then at the bottom, patient has a nice disc replacement. Again, another one, cord compression, and subsequent surgery with a disc replacement. This was some of them are easy, some of them are harder. You can see this patient has a autofusion on the CT scan. You can see here, because of that, the weak segments were above and below it. So he herniated above and below that area. So it's really spanning 4 levels. And I went ahead and did a disc replacement on him. And here, this image, you can also see again the disc above, really pressing on the cord. Yeah, just did the disc replacement above and below. You can see here the metals, and going back to regular work. This is another patient. So it can tell you about recovery and how long it takes us to get back.
I had a dual disc replacement, C5 to C6, C6 to C7. So far, progress it's almost exponentially improved, especially in the last 2 to 3 weeks.
When was the surgery? How long ago?
September 30th, so 7 weeks, 2 days ago.
Perfect. Are you driving right now?
I am. I was driving within 7 or 8 days.
Okay, great.
Yeah.
Wonderful.
And at this point, yeah, I almost have to remind myself like not to do things because the pain, everything is gone. Like it feels like I can do more than I should at this point.
What's your neck? Let me see this car. Sure. Okay. Okay, sounds good. Okay, wonderful. Thank you.
Okay, and then you can see here, like this patient I saw, you can see the discs here. I'm sure everyone can appreciate this is bone on bone, bone on bone, bone on bone on bone on bone. So 4 bad discs. And so what do you do for this? You know, that you do a 4-level fusion. She was told she's a 4-level fusion. And so I saw her for a second opinion, but to me that's a pretty drastic essentially surgery because you'd be disabled. I mean, doing a 4-level fusion is pretty disabling. Let me see. So I end up doing a disc replacement. You can see 4-level discs, did amazing. So this is just a few notes about anything more than 2 levels. So it's not FDA approved for more than 2 levels. But again, we do a lot of things off label. There's even pedicle screws. I'm not sure if anyone knows this. Some is off label. So there's a lot of things we do is off label, but we do it based on experience, and the results can be very good. A lot of times we have problems getting authorization for these, but again, the carriers who do authorize it, the patients do really well. This is another one. Patient was told that they need a 4-level fusion. I did the disc replacement, and here's the.
And I had a 4-level cervical spine disc replacement.
Oops.
Dr. Mir, October 2nd. Today is November 20th. My scar is healing very well. You can barely see it if I'm not looking. My range of motion is really good. The pain that I was having in my arms and my hands has gone away. Just working through the stiffness. Thank you, Dr. Mir.
Of course, can't blame them.
And don't forget, this patient was like only 6 weeks out, so the recovery is very quick. But also, you know, sometimes you do need to do a fusion. You can see this patient had a pretty bad retrolisthesis. You can see the vertebrae is moved backwards, which is shown by the red lines. And so I had to do a fusion to bring it forward to kind of fix it. So not everyone's a candidate, but many people are. And sometimes you have to do a hybrid. That means 1 level is a replacement, the other level is a fusion. So you can also mix and match it. But again, it's off-label use, and many times it's hard to get authorization for this. So a few words about lumbar disc replacement. And this is another area. I've been doing lumbar disc replacement for a long time too. I first did it through my fellowship at Cedars, and patient's doing great. This implant has been around a long time, and the results are great. But back then, it There was another implant, Charité, which had a lot of complications, and that's the reason disc replacement went out of favor. But this disc particularly have done really well, and the results have been really good. And this is what it looks like on the x-ray. This is the front view, and the one to the side is a side view. This is another one. This is a 2-level disc replacement. By the way, at any point, if anyone has any questions, please raise your hand, or we can go over it. This is a patient.
I'm Graham Jacobs. I had 2 of my lower discs replaced in my spine, and I've been going through physical therapy again to get my lumbar disc back, and I'm able to touch my toes again as of today.
Oh, nice.
Yep, so that's a little over 2 months ago. I had surgery, so I'm a lot more limber than I used to be, full mobility back, no issues.
Very
I just
good.
need to take care of my neck.
I'm glad you're doing better.
So just in general, I want to just review the anatomy of the spine. You got the cervical disc, thoracic, and lumbar, and a lot of the motion comes in the neck and the back. That's where you see a lot of wear and tear. The thoracic spine is because the rib cage, it doesn't move, so therefore you don't see a lot of pathology, but sometimes you do. You have the joints in the back, and you have the disc in the front. The disc is analogous to a tire, so you got the fibers or the rubber, and inside you have the gel, which in a tire you have the air. So those are the 3 elements, like a 3-legged stool. And inside here you have the nerves. So we have when you have a herniation, the disc comes out and starts putting pressure on the nerve, and that's where you get the sciatica shooting down the legs. So part of a workup is very important to get an x-ray, and the x-ray needs to be bending x-ray. So when patients are seen at either urgent care or a chiropractor's office, this x-ray is not done. So this requires a special type of x-ray, which quite frankly, some people don't have this equipment, or if they do, they don't know how important it is to get it. But it's really important to see the movement and if there's any signs of instability with motion. You can see here, this x-ray shows no movement, but when they bend forward, the discs are really separating. Same thing here. This patient saw me for a second opinion, had a previous surgery, disc replacement. She kept complaining, but nobody took any x-rays, any bending x-rays. So when I took an x-ray in the office, I can see how forward and how unstable this level is. So I had to go in, remove these discs, and do a fusion because it's very unstable. So one big issue is the quality of the MRIs. We try to get a closed MRI because nobody wants to be in a tube for a long time, but you do lose quality. So it's better to be in a closed MRI. If patients need anything for anxiety, we can give it to them. And then it's also important to get at least a 1.5 Tesla magnet and a good radiologist. Sometimes, these radiologists are not paid well. They spend very just minutes on these reports, so they're not very detailed, and the pathologies are missed. And unfortunately, when everyone else, such as the utilization review, they see these reports, they're really basing it on what the radiologist said. And if the reports are not accurate, then patient will be suffering and they can't get help. And it's really hard to repeat the films because they won't authorize it. So it's good to get it done well and done right the first time. And so that's very important. You can see here on the left is a strong magnet. To the right is an open, weak magnet. You can see the one to the right, you can't really see anything. But the one to the left, everything is very clear what the issues are. So how do we treat disc issues? So when a disc comes out or when there's any sort of a inflammation, there's 2 components to this. One is a mechanical component. The disc comes out, puts pressure on the nerve, and then the nerve gets swollen. So the first line of treatment to get rid of the chemical component, that's by resting, steroid therapy, and things like that. So you want to shrink the nerve. When you shrink the nerve, the space gets bigger. And that's the first line of treatment. And we also do epidurals. Again, epidurals do help. Again, you're trying to shrink the nerve. And there are different types of them. There's interlaminar, transforaminal, and caudal. There's a picture of it showing caudal. This is generally for older people that have multiple levels. So you inject the steroid that kind of spreads. Here is transforaminal. That's one I like. You go from the side, you need x-ray guidance, and you inject the medication. And this one is interlaminar. This one you gotta be careful. Sometimes first it's not very direct, and also if a patient has a lot of stenosis, it can puncture and injure the dura. So my favorite is this one. And then some people have facet arthropathy, which they need to get facet injections. So these are pretty much the type of injections that are available to the lumbar and cervical, both. Then, of course, if the mechanical component is to be addressed after the chemical, then that means surgery. So you got to go and take the pressure off to release the compression on the nerves. I personally like microscope. I use it for everything. I don't like loops. Microscope is nice magnification, illumination, and it makes things very safe. Even with revision surgeries, you see the scar tissue very well. So overall, makes it very safe. So in spine surgery, particularly, less is more. And what I mean by that, you have patients that have multiple problems, multiple issues, but you got to really narrow it down. You have to see what's causing the pain. Where's the pain generator? And for that, I need to be able to order more films. Sometimes I get a CAT scan to kind of look at the bone spurs a little bit, to kind of really find the target. You want to find the target. If someone, for instance, has 4, 5, 6 levels, you want to say,
Dr.
okay,
Mir,
which one? Yes.
do you have a minute for a question real quick?
Yes, absolutely. Yeah.
Okay. It's what are some indications they can look out for for a quality diagnostic facility or radiologist? Do you have some indications they should look out for outside of the 1.5 Tesla magnet?
So 1.5 also closed. I know people don't like to be in a closed MRI, but again, it should be closed because the quality increases. When it's open, there's more artifacts. So that's really important. The radiologist, some of it has to do with the reputation of the radiology centers. Some good ones, some are bad, and some centers is mixed. Some centers really, sometimes they read it well, sometimes some branches have good radiologists, sometimes you get stuck with a bad radiologist. But they need to be accessible. So you don't want a radiologist that you call them, they don't call back. But that's definitely a big challenge and also, well, one of the big issues is that we know what centers are good, but unfortunately, when it gets authorized, one call calls them and they send it to wherever they want. So it kind of gets out of our hands. And nothing is worse than patient goes, gets the MRI, and they come back with a bad MRI. Or even worse than that, I ask for a repeat MRI. They go get a new MRI, and it's still the same thing. So no one really looked at why we're doing the MRI, why we're repeating it. And it's very frustrating for the patient and me and our staff. Does that answer the question?
I believe so. I'll keep an eye out for more questions. Thank you.
Sure.
Go on.
So there are a few types of surgeries. Even like when you do a lumbar laminectomy or decompression, I think it's a term everyone has heard, but the different ways of doing it. Either you do a full laminectomy, which is classically been done. Most people do a full laminectomy. You can see it in the bottom where the complete spinous process is removed. And imagine if you have a couple levels, you have a big space. which that can cause pain in of itself. I don't like doing that. I like to keep the spinous process, which is the tip, which you see it on your back. You can, if you just run your finger down your back, you can feel that spinous process. So I like to keep that and really work on the side of it, like kind of make a little opening on the side. And it's very tedious. And if you have to do both sides, then you have to do bilateral. It's supposed to just removing a big block of bone. So if you think about it, if you have to do bilateral 2-level, then that's 4 holes you got to do. So again, it becomes a little tedious, but I like it because the outcomes are very, very good.
One more quick question.
Mm-hmm.
It's in regards to, do the issues mainly lie in how the radiologist reads it or bad imaging? If it was read poorly, couldn't they just take the imaging and request a secondary reading by someone else without having to do a second MRI?
Yeah, that's a good idea. I just don't know how to do that. I mean, when we get authorization for an MRI, they do the read and is the facility. So the question is, how do we get another radiologist, like an independent almost radiologist, to read these films? Yeah, I mean, if anybody has any ideas, please share with me because I've not been successful at that.
Okay, thank you.
But you're right. That would be a great alternative to repeat the films, to have a radiologist read it, like a separate radiologist. I think that would be amazing if they approve it. Yeah, that's a great question and a comment.
One more question, perhaps
Yeah.
pertaining to that.
Mm-hmm.
Let me go ahead and do the MRI facilities check to see if the results are from an old injury? Can they estimate if how old? I think like aging of the duct.
Yeah.
They have to. Go ahead.
Yeah, I mean, it is hard for the radiologists. I mean, some of it has to do with the history. First, if there any prior imaging. If the center has the prior images, they usually do a comparison if it's worsened or not. But as far as what's new, sometimes you can tell if you have a fresh annular tear. You can tell it's new, but sometimes it's an aggravation. It could be an aggravation of pre-existing condition, and so that's going to be hard for them to determine. But sometimes they can, sometimes they can't. And moving on this slide, you can see partial laminectomy. Again, it's what the red line shows. You just go in there, kind of trim that off, and it's pretty, actually, very quick surgery and really outpatient. They go home, and the results are really amazing. Outcomes are very good. So this is another patient that is not a disc replacement. It's not anything. I just did that for amniotomy and that partial laminectomy.
Can you walk for me?
Yeah, I walk right now. Because I can't put weight on the right side, basically. So you can see me leaning to the other side. So every time I put weight, you can feel the pain.
And you're kind of leaning forward.
Yeah, leaning forward, yeah, because I can't lean back either, because I'm getting pain too.
I see. Okay.
Yeah.
Okay, sounds good. All right, so when was your surgery?
About 12 days ago.
Okay, how you doing?
Awesome, man. You're the best.
What changed?
I'm upright now. I'm not a caveman anymore.
So let's see one.
I can look straight now. Look, there you go.
Okay, nice. Okay, perfect. So, are you taking any pain meds?
No, I haven't been taking pain meds for 3 days. Just a little achy, but it's so great.
Okay, good. I'm glad. All right, are you driving?
I'm driving.
Okay, very good. Nice. I'm glad you're doing better.
Can
you walk?
All right. So again, that patient was the partial laminectomy, and this is on the left. I want to show you what it looks like when you do full laminectomy. You can see the back here. I'm not sure if you see my arrows, but you see there's no muscle. So you're supposed to see some muscle here. It's all white. That means fat that has grown where the muscle should be. And so it's a muscle atrophy, essentially. And if you can imagine, that gives a lot of pain. And to the right, I did this partial laminectomy. You can't even see it. There's a little on this side, again, on the arrow, I'm showing that I did a decompression. Partial laminectomy, you take the pressure off, and these patients look great. You can see the muscles in the back, very viable. And at the end of the day, you need muscles. I mean, if you don't have any muscles, you're gonna get pain. And people, I think, don't pay attention to that. So again, difference between full laminectomy versus partial laminectomy. Another thing I do for some of these older patients is when this patient has scoliosis, and instead of doing a full fusion, multiple levels, I do a decompression and just put a wire with some bone around the spinous process. And they also do really good. It's a small incision, and they go home same day. So you're avoiding a big surgery on these older patients because anesthesia is very important for these patients. You don't want to keep an older patient under anesthesia for a long time. So this is an example of a discectomy. The other one was a more of a degenerative stenosis when it closes up. This one is discectomy. That means you have a herniation, and the surgery consists of removing that fragment that is pressing on the nerve. On the bottom right, I want to show you what it looks like when you remove the disc. There's a hole in the disc. So the first 3 months, you need to be very careful because another piece can spit out, and that's important for the patient to be careful. Also, the physical therapy facility they go to, so they need to be very careful not to overdo it. I usually tell them do a lot of stretching initially, and then wake up the core. If they become aggressive, you really risk another disc spitting out, which is called a reherniation, and that can, essentially causes recurrence of the pain and sciatica and things like that. Also, I've done stem cell on very select patients. That's really your own bone marrow you take out and you spin it and you inject it. And you can see this patient was told she needs a 3-level fusion. I ended up doing a discectomy on this one, the top level stem cell. And you can see over the 1 year how the disc on the top healed and the edema, the white spots, kind of significantly diminished. There's another patient. I did a discectomy and then did the stem cell. The MRI to the right, you can see is completely normal. There's very nice healing. And sometimes you got to do fusion, so there's a instability, there's a pars defect. So you got to stabilize this. There's different ways of doing it. You can go in the front, which you can put a big graft. You can go from the side or all posteriorly. I'm sure you've seen these in different op reports. For younger patients, I like to go in the front because you can put a pretty big graft in there, and that increases the fusion rate. I also use bone. I still a little bit old-fashioned in that regards, that I use bone because bone fuses with bone very well. Some of the metal cages don't do as well. They subside and doesn't fuse, or the fusion might be very tenuous, so the patient has persistent pain. This is an example of a fusion where I can see the bone and this small plate in the front. And sometimes I put screws in the back, but again, I'll put the screws in the back also using a microscope, again, small incision. And some of these would be outpatient too. So we keep them 23 hours and we have them go home because of small incision, the pain is very minimal. So the post-op for these patients are really, they take pain medications for a few weeks, and we see them back in about 10 days. We check the wound, and then they can shower, get a wet, and then we see them maybe 4 to 6 weeks afterwards. We generally start physical therapy about 4 to 6 weeks, unless they have a foot drop or something. I want them to start sooner. One of the reasons I delay this therapy is because the therapies don't screw things up. And again, I prefer for one call not to call these patients because I also try to find a therapist who's qualified to perform the physical therapy in these postoperative periods. So these are like patients are very fragile. You want to kind of have the right therapist to get them back. And then my goal is to put them on some sort of a modified work about 3 months, or even have the discussion at least with them to kind of see where we are with return back to work. So after the surgery, these are some of the exercises that tell them many patients are tight in their hamstrings, and the best way to stretch the hamstrings is really lie on their back and to use a band, because this way they've isolated the back and they can stretch their hamstrings. I tell them to start doing the cat cow pose. You can see here to kind of mobilize the spine so they don't get stiff. So not moving is not very good either, because you want to move your spine so you don't get stiff. Um, these exercises such as plank are also very important. You want to wake up the core, let the muscles fire up. Also, this is called a Superman pose. It causes a lot of back strengthening the lower back muscles. This is what we do when we're a child. By 3 months, you're on your belly, and that's how it strengthens your back muscles. That's what the next stage is for the kids to sit. So these are important exercises to do
Quick,
to wake up the muscles.
quick
I don't.
question.
Mhm.
Are these also preventative exercises, or are these really specifically after the surgery?
No, good question. No, preventative too. We should all do these exercises. Yes. I mean, I really like and encourage my patients to go do yoga, because in yoga classes they do a lot of these. So, and the different levels of yoga. You don't need to do, like, if you have some stiffness already, you don't need to do a difficult class. You can start with like beginner yoga. And the nice thing with yoga is you kind of limit yourself. I mean, if you don't need to follow what the instructor is doing, you can just
Quick
kind of stop.
question. How about Pilates too?
Absolutely, I love Pilates. So there are two types of Pilates. One is mat Pilates. The other one is reformer. They're both really good. The mat is a little more controlled, because again, you can kind of control your core and how much you can do. Reformer is very good, but it really needs to be one-on-one, because some of these class, unless you really know what you're doing, then you can do a class. But doing a reformer in a class setting can be dangerous. Um, I've seen some accidents because the bands can kind of start flying away, and this it's you may stretch things too much. So yeah, so mat Pilates is very good, especially mat Pilates, and also yoga with stretching exercises. And it's really not for the back, also for the neck and for all the joints, for shoulders, hips, knees. I think this is all important. Now, talk about the neck. I mean, people think, okay, well, what is there to do with the neck? You don't have much muscles. But really, the big thing is the upper back. When we start leaning forward, our shoulders roll forward, first it screws up your shoulder because the scapula is moved forward. That's why you get impingement syndrome and issues. So you just want to move the shoulder back like this, and then strengthen the upper back muscles. So for that, a lot of people are stiff. So you need to be in a roller and just kind of stretch their upper back muscles, and then do a lot of scapular mobility. So you probably see when people walk, they're going like this. That's actually very good, because you're kind of making your scapula move. So these motions, people use a band. So what that does, actually, it does take the pressure off the neck. And the way it works is, once you go like this, you start going like this, and it's loading the facet joints and everything. It causes bone spurs and other things to build up. Once you fix that, then it really takes the pressure off. And but I can tell you, so many people go to therapists and no one is addressing these. So it's kind of frustrating. I got to teach them, and it's just not possible because I'm not, I can't do a one-on-one for an hour with them because they need someone to work on them. So again, that's very important. So for people on this webinar, you may want to get one of these rollers, these long rollers. So really put your butt down here, and you can rest your head on this. And you kind of put your feet down so you can stabilize it, and just let your shoulder kind of relax. You should be able to kind of go up, but sometimes what happens when you go up, your shoulder kind of rides forward. That means your shoulder is tight. And all you got to do is really like go like this, and then let it just sit there for a minute or two. It will start dropping. But you got to do it every day. Some of these exercises, you got to do it every day so for you to open up. Because there's no point in strengthening the back muscles if your your pec is tight, because you're not, first you got to open it up, then strengthen the back muscles.
It's better to invest in a foam roller than have surgery, down the road, right? Because the foam roller is what, $15-$20, and surgery is pretty costly. So
No, absolutely. So a lot of it's prevention, but also when I do surgery, like people have already too late. They have the bone spurs, the pinching going on. I tell them, I'm like, we can do the surgery, but you got to do these things. You got to fix some of the underlying issues. Otherwise, you'll be back, and you have persistent problems. So sometimes I've also seen, for especially women, the breast kind of drags them down, and they can't stand up straight. So I tell them maybe a breast reduction might be appropriate, non-industrial, and because it does play a role. So in general, I don't like to talk about my outcomes, but I'm just putting this in there. This is some, at the local hospital here, they give our outcomes, benchmark it between different surgeons. So I do have pretty good overall outcomes compared to my peers, like revision rate and readmissions and things like that. And so we just recently moved to a new office in Tustin. I take up the entire space on the top floor, which I've added different disciplines such as a general orthopedic surgeon, sports medicine, pain management, do some acupuncture and things like that. So we can kind of have it's really made it so much easier to, when I have a patient, before I didn't have a pain management, it would take them a couple months to get into pain management to get a shot. And then, so the whole thing was really dragged. Now we quickly get the authorization. Within a few weeks, they're getting their shots, and I see them back, see how they're doing. We're just kind of moving forward. Whether, some people need surgery, some people know they get better, and then we can kind of PNS them and discharge them. So the whole thing is really moving very quickly for us, and is
one
making
thing for you, doctor, I know you said you can see stats like on the same day or the next day, but on an average, is it what, 3 days, 7 days to get an appointment with you?
Yes.
Okay.
But I am putting a mechanism that we can see them stat within, a day.
The stats within a day,
Yeah,
absolutely.
I'm also putting a mechanism of doing an orthopedic urgent care here, so they can come in, walk in. With some of the established patients, obviously, we need to get authorization for that. But I will soon have an orthopedic urgent care. And yeah, so we have different services offered right now. And let me see. That's it. So they asked me to put some pictures of my family. So here's some pictures. This is our trip. So it's the only way so I can relax is go on trips, and to keep my mind off so I can come back more refreshed and see patients. So I like to travel in winter time and summer, a couple weeks. So The winners are, I think, amazing in Europe, and that's what we try to do that. This is Strasbourg in France. If anyone hasn't gone, it's really a magical place. Let me see. There's another one. This is Switzerland, Greer, the cheese town in Switzerland. So this is my family. This is my wife, 2 daughters, and my
You have
son.
some people agreeing with you. Europe is amazing. Yes, absolutely. By the way, while we're talking, anybody else have any questions regarding anything, please feel free to raise your hand or chat in the question area before we log off here. But you will be getting a copy of this presentation, correct, Diane? Or they can get it off the website.
Sorry about that. Yes, the PDF was actually too large to attach. So if they would email me at, here, I'll jump on real quick, at diane@macropro.com. That's DIANNCOHEN. No, actually, there's no Cohen at the end. It's Diane, DIANN @macropro.com, and I'll be happy to send that to them.
Great, thank you. And then, yeah, there's one more last picture in Milan. And I think that's it. Yeah. So we can go back. Any questions? We can, I can pull up the slides, and please feel free to ask any question you like. And just in general, let me just talk briefly about my return back to work. So as I mentioned before, we tried really hard. I do put the restrictions and send the patients back. Sometimes the employer doesn't accommodate, but we do my part to send them back. And it's very helpful when the employers accommodate the restrictions. It really helps a lot. And then the ones who do, we keep lowering the restrictions until we kind of optimize that, and then I discharge them, do PNS, the patients, and they get discharged, get ratings and everything. I'm also a QME and AME, so I'm pretty familiar with all the ratings and things like that.
You also have offices, in Long Beach and Riverside?
That is correct. Those are my satellite offices in Long Beach and Riverside. Correct.
Okay, so
Doctor, I have a couple questions. We have a little bit of time, so we make sure we hit our 50 minutes so everybody can receive their certificates. So please hang on, everybody. Make sure you don't log off so we can get to 50 minutes.
Okay.
And you get that.
I have one too. I have one too. Do you want to do your, as I work for an employer. Oh, it's just a comment. They love your return to work. Yes.
Okay, excellent. So doctor, can you tell us what is the most challenging thing for you when trying to get approval, or what is it that you're finding the most friction with? Because if we can discuss that now, maybe we can fix it on the claims end.
I mean, the most frustrating thing is some of those utilization doctors, some of the carriers use particular UR people, and they're injecting their own personal opinions or just inappropriate denials. And really, really is bad because now the pain becomes chronic. The outcomes, even with surgery, is not good. Patients get frustrated, it gets litigated. It's just, I think, denial. I think that's my major thing. And that's why some of these, the employers who, they authorize things pretty readily, I think it's really helping everyone. And I think patients are happier, the outcomes are better. So the denials is the most frustrating thing.
Yeah, it's always interesting because they give you a referral and then there's a denial with the referral. So it'd be really great if we were able to figure that out. I know that happens throughout our system, and workers' comp system is not perfect, but here in California, we really do our best to make sure we take care of our injured workers. And I think that's quite important. So doctor, thank you so very much for your presentation and everything you had to share with us. It was very interesting to see and hear the patients talk and how quickly they were moving around. It was very impressive to see the outcomes that you're getting. Cindy, your speaker is off, but maybe would you like to say anything in closing? Because I know you'll be retiring soon, and we are going to miss you so much in the industry. It just will not be the same without you.
I'll be honest, semi-retiring. I will be doing a little work with Dr. Mir as well as Joanne Para with MedSource, but I will be semi-retired, so I won't be doing all the big conferences and everything. So you'll see me here and there, some of the small pharmas, COSIPAs, and that type of stuff.
Okay, well, just as a reminder to everybody, your CEU should arrive in about 1 hour, so make sure you look for that and download it immediately. If you have any problems, please let me know. Again, I can help you within 30 days. After that, I cannot. We have 3 outstanding webinars coming up next week. So the first one's going to be navigating some of the most challenging workers' comp issues with James Rossi. We also have advanced orthopedics with Dr. Hamid. And then on July 3rd, we're examining clinical pathways for occupational injuries. And so we want to make sure that you guys know that they're available to you, and you can just go to macropro.com and sign up for those. This is our second installment of 10. So we hope to see you again shortly. Dr. Cindy, thank you all very, very much.
Thank you all. Now. Appreciate it. Thanks for your time. Take care.
Bye-bye.
Thank you, everybody.
Thank you, guys.